Well, I was this evening by welcoming everybody to this presentation. This is a SDSMA Center presentation on patient safety and reducing risks at transitions of care. This presentation is brought to you by the SDSMA in partnership with MIC. We're going to go ahead and leave all phone lines open this evening so that way you can interact with our presenter and you can ask questions. If we do start to pick up considerable background noise, we will go ahead and mute lines to make it easier for everyone to hear. If we do mute lines, we'll make that announcement made so everyone knows, and then we will throughout the program so you can ask questions, and we will have a Q&A period at the end of the presentation. At this time, I'd like to go ahead and introduce Robert Thompson with MMIC. Robert serves as the Director of Education at MMIC, and he has diversified background in law, medicine, medical professional liability insurance, and care risk management. Thompson specializes in patient safety, risk management, and healthcare communication. I'm going to go ahead and turn it over to Robert and ask him to introduce himself and then lead us through tonight's discussion.
Thank you. I appreciate the opportunity to be here tonight and get the opportunity to talk on this topic of transitions of care and patient handoffs. That's been interesting in the development of this program over the past couple of weeks, putting everything and kind of getting it rolling. I've had a time to reflect back on the presentations that we've done over the past year in this venue, and it's interesting how many of the topics that we've discussed, patient and team communication and documentation and follow-up systems, and issues and others that impact patient handoffs, where all of those kind of come together to have a huge effect on how well we do what we do with patient handoffs in all settings. We'll talk about individual specialties and count on some of the issues that we see in those specialties with patients and transitions of care. And I'd like to start by the transitions of care traditionally something that's looked upon that's focused on the inpatient setting. But we'll talk both tonight about patient and outpatient and the patient handoff processes in those settings, transitions of care or patient handoffs, whatever terminology it is that applies to the inpatient-outpatient setting. And I think that it's important to recognize that it's the entire community of healthcare that participates in making sure that transitions and patient handoffs are done correctly. And I think it's also important to recognize just how big a part the patient plays in the position in these handoffs. With that, I think it started by talking briefly about how we have come to this point that we are at from an educational standpoint, looking at those topics that I just ran through with you: patient team communication and patient engagement, follow-up systems, patient handoffs, transitions of care. All of these fall under the purview of patient safety and risk management. But with an interesting change at MIC in the way that we look at what topics we're going to work towards, trying to find where our resources are best applied. In 12 months, we have formed a relationship with CRICO, and CRICO originally started as the insuring arm for Harvard University in Boston, Massachusetts. And they originally were one of the first groups that started collecting significant amounts of malpractice claims data, basically looking at closed malpractice claims retroactively. What their goal and objective was to try and look at what was happening in those malpractice claims, particularly looking at the clinical aspect of those malpractice claims, and then try to be able to take that information and turn it into proactive risk management and patient safety strategies. For years, we've collected malpractice data. The vast majority of that data was financial, so I could tell you what the average cost of a malpractice claim in Nebraska would be for an orthopedic surgeon operating on the spine, for example. the type of information doesn't do us a whole lot of good in trying to prevent that claim from happening again. And Cryo was collecting significant amounts of clinical data in their malpractice claims, and what they started to recognize was they could put together very solid systems that allowed them to put together programs and educational sessions and policies and procedures that reduce the risk of that same type of incident occurring again. Problems with CRICO being that they were kind of geographically isolated in Boston, Massachusetts, and that they didn't have enough malpractice claims in their system to be able to provide statistical significance to the data that they were collecting. So about 10 years or so ago, they started partnering with other entities. And if you look at the map that's up on the screen right now, everything that's in orange there is a contributing entity to the CRICO or the benchmarking services data collection efforts in 2014. And if you also look, that swath of the Midwest is MMIC. So done a pretty good job of partnering with institutions, entities, and companies across the United States, but what they were lacking was that big swath in the middle that we provide information for at MMIC. So an opportunity for them as well as an opportunity for us. And so now we have access to data that represents 30% of all of the claims in the National Practitioner Data Bank. And in the 12 months, we've entered the 3 years of data from MMIC. And that allows us to slice and dice data across geographic areas. It allows us to benchmark and compare ourselves, other entities and other organizations across the country. This gives you an idea of the statistical significance of the database. So there's excess of 300,000 malpractice claims representing in excess of 100 healthcare entities, 165,000 providers, which of 8 to 10,000 malpractice claims being entered into the system. And again, this is still growing with the addition of XC and our states in the central part of the country. These numbers are even larger now. So if you get some of the participants that are in this CRICO system, there's some big players and some heavy hitters from an insurer standpoint: the Doctors Company, Medical Protect, MMIC, Med Insurance Exchange of California, all big names. University of Florida Shands, University of California, UCLA, Stanford University. And then some of CRICO's members themselves are, again, heavy hitters, Mass General being one of them, Brigham and Women's Hospital. So all of the malpractice claims from these entities for years have now been entered into the system. To give you an idea of what we look at here, this is a methodology that was established in 1990, and it's to learn from malpractice claims. And so CRICO does have proven success. If you look at an OB physician who practices in the CRICO system, they pay about 60% of what another OB physician that practices next door that is outside of the CRICO system pays in malpractice premiums. That effect that they have been able to have on patient injuries and subsequent malpractice claims. So there is proof in the pudding that have been able to put together in this retroactive look at medical malpractice claims. Inside this database, they capture 650 proprietary codes, looking at the clinical and monetary details of those claims. All coding is done by experienced nurses or nurse attorneys, and they have pretty significant oversight to make sure that no one in the system is stray. They have overview where CRICO will go across the country and make sure that these codes are being entered and into the system in a similar manner to make sure that that we're getting good solid data coming out of this system. Give you an idea of how deep this digs, and up to the point of what brought us to where we are today. So, looking at this CRICO system, they look at a claim where the primary category is clinical judgment. We stopped at that point when looking at medical malpractice claims, but this detail in this system, in the 650 proprietary codes, digs deeper. And so if you look, the detail level under the patient assessment issue side looks at differential diagnosis, history, and physical failure out abnormal findings. So we dig down into that detail and look at patient monitoring. And again, there's a number of categories under patient monitoring. And so it is that digging that we have seen in a system that has allowed us to get where we are today in our educational efforts. And it's amazing how closely what you all have put together has tracked with where we're heading at NMIC. So some knocks on this system, on this CRICO system that has focused our initiatives and our efforts. One of them is that it's a small number, that it's not statistically significant. We've talked about that. Rotation of 30% of the national practitioner database oddly has statistical significance. A knock that has been put out is that this is aged info that the getting on malpractice claims has been heard and already been addressed and has been fixed. Point is that if that were the case, we wouldn't still be experiencing these repetitive malpractice claims over and over and over again. So if you look at this iceberg theory that they have here, this visible unique event that happens, to focus on that. What we have wanted to focus on is the not so visible or the unique underlying issues, or the contributing factors to the malpractice claims that we see out there. And we know that we can do something about those contributing factors, that we can address these issues that are leading to these patient injuries. And that's in large part the topics that we have addressed in the past couple of programs: documentation, patient communication, team communication, and program comes from tonight, a contributing factor. And so we get where most of these claims are coming from. And what we find is that diagnosis issues, failure to diagnose, misdiagnosis, delay in diagnosis, these are coming from. Most of our claims are coming from. So if you look at this next slide on the left-hand side, you look, these are MIC numbers now. So there's 1,429 cases that we're looking at. And what we find is that number 3 on the list as far as the number of cases is diagnosis issues. Draw your attention to is the cost of those claims. So the total incurred in the black there. Actually falls number 3 on a list of incurred dollars incurred for those malpractice claims. Somewhere around the $27 range. So big dollars. And if you look at OB related cases, we expect those to be there. We expect to have high dollar when it comes to OB. You can see the number is small, but the dollar associated with those is large. All very difficult for us to address related issues because there aren't the contributing factors that are present or as significant as we find in diagnosis-related claims. So if you look on the right-hand side of this, our comparison to our peer groups, and we actually, from a percentage standpoint, our percentage of cases is less in diagnosis than that of our peer groups, still tracking fairly closely. And then looking back at the left side with that total incurred of such a significant dollar value, understand that this is an area that we have been focusing our attention and that we plan to focus our attention on in the future. Diagnostic error is extremely prevalent. It occurs in about 15% of all actions, medical interactions. I also understand that diagnostic error is extremely serious, and claims involving death diagnostic errors the most frequent allegations. So what to really do is look at where these types of errors are happening, what are the underlying causes or contributing factors to these claims, and can we do to address those. So look, diagnostic error occurs everywhere. I mean, it's all facets, all areas of healthcare, and that's an opportunity for us, inpatient setting, outpatient setting, pharmacy. It'll allow us to have a broader spectrum and a broader area to address these underlying causes. This is a slide that kind of looks at diagnosis-related claims and then breaks down into ambulatory and inpatient setting. And so if you look, these are more prevalent in the ambulatory setting. About 50% of all diagnosis-related claims happen in the ambulatory setting, and about 8% of those types of claims happen in the inpatient setting, and they break ED out individually here. If you look at severity issues, high severity percentage of those claims in the inpatient setting is more significant at 73%, and 46% of deaths result in the patient setting. But that's something that we expect. We expect there to be more critical cases in the inpatient setting. And so the focus from CRICO and the focus from MMIC has been more placed on the diagnostic-related claims in the ambulatory setting for a couple of reasons, not the least of which is that those contributing factors, handoffs, patient and team communication, we can impact those more appropriately in the outpatient setting, than we can in the inpatient setting. So the focus from CRICO and the focus from MMIC and look diagnostic error is going to be more focused on the ambulatory side of the house. This gives you a breakdown of what we see in the 56% of diagnosis-related claims in the ambulatory setting. If you look at 50% of those cases are broken down into medicine, and the largest contributor is family medicine at 17%. So we've been seeing a shift in the riskiness of family medicine and general practice and family practice in 10 years or so, to the extent that I can make a fairly solid argument that family practice and general medicine categorized as a high-risk specialty, not only in the percentage of cases, but in the indemnity, average indemnity paid in particular cases. Diagnosis in ambulatory cases were cancer number 1, cardiac number 2, and then injury cases, orthopedic and spine type injuries, 3 on that list. Some of the breakdowns that we see in the process of care in the ambulatory setting, if you look over to the right-hand side of this in the percentage of cases, you can look at the steps and see where the high percentage of cases are coming in those particular steps. Evaluation of systems is found as a breakdown in 28% of cases. Diagnostic processing, diagnostic focus or failure to establish a differential diagnosis, something that we'll talk about a couple of minutes in the patient handoff portion of the program, coming in 34%. The ordering of diagnostic tests, 13% of the time that's prevalent. Interpretation of test results, 21%. Physician follow-up with patient, 19%. And then the communication issues down at number 11, prevalent in 13% of those cases. So this gives you an idea of where the breakdowns are occurring that are leading to the issues in diagnosis. You can see how cleanly these fit into the folks we have educationally, and that the programs we've done in connection with the Medical Association over the last year also kind of focus on these areas where we see the high incidence of issues related to diagnosis. So the CRICO outpatient cases, you can see, their numbers are even higher as far as focusing specifically on diagnosis-related issues. No cases close to 100, and then the total incurred around $220 million. So a high count, and then also high indemnity paid for diagnosis-related claims. You can see a comparison here with inpatient cases and outpatient cases, and then what are the contributing factors. We always expect clinical judgment to be right at the top of these issues related to malpractice claims. That's the reason that physicians and hospitals have malpractice coverage, but the numbers that fall in line. Communication, 1% of cases in the patient setting were attributed to communication error. In the ambulatory setting, 24%. You can see how these contributing factors that we are focused on pop here. Documentation comes into play in both. And then fear or delay in ordering a test falls in the category down in the ambulatory setting at 30% of the time, 17% of the time in the inpatient setting, and then again communication pops up. Communication among providers in the inpatient and the outpatient setting at 10% of the time, and in the inpatient setting at 20% of the time. So all of these issues that we have looked at come into play under that larger guise of delay in diagnosis, failure to diagnose, issues related to diagnose. So moving on to topics tonight and looking at care, issues related to patient handoffs. And, the first thing that we need to address in looking at those issues are breakdowns in communication. And I know that we did an entire program on communication last, but that these focus on where communication issues related to the breakdowns and transitions of care and patient handoffs. Give you an idea that some of the areas where we see the significant problems in transitions of care are in the report breakdowns in communication that lead to a failure to report some of these types of issues. A change in patient's condition to the physician. They report a pending test result at discharge. Failure of surgical complication to the covering provider during sign-out. Or failure to report an accurate list of medication at transitions of care. At the time when a patient is being transferred, and again, you look at all areas of care, this can be from physician, from a patient setting to a specialist, from the ED being admitted to the floor, from a hospitalist or hospital assistant being sent back out into the primary care or ambulatory care setting, and that we see that handoff of a patient from care facility or one provider to another. There's that opportunity for breakdown in communication that can lead to patient injury and a malpractice claim. And often it's a general breakdown in communication. It's not something that is so focused on the clinical side of the house. And it causes us issues because those are service-based types of claims. Those are service lapses as opposed to clinical lapses. It's very hard for us to explain to the jury that there was a test result at discharge, and somehow or another, because a nurse was changing shift or a physician was changing shift, there was that communication between providers, and so the communication of that test result was made to a patient. If we have a patient that suffers an injury because of an issue like that at transition or an issue like that at handoff, very expensive malpractice claim because American juries don't expect that type of issue to come up. They don't expect that type of result, and to be very punishing when we have an unfortunate error like that. Breakdowns in communication lead to a number of things, and if you can sit there at the top of it, misdiagnosis or failure to diagnose, a delay in treatment or some sort of inappropriate or untimely treatment, care, increased hospital stays, readmissions, all which lead to increased cost and inefficiency. So breakdown in communications, particularly those transitions of care or patient handoffs, tend to lead to a number of negative issues for us. And a significant number of contributing factors result in these failures at transition due to communication. Skills and training. You can see this coming together of all of the topics we have addressed last year. The last program 3 months ago had about half of the time was focused on teamwork, team issues, communication between physicians and nurses, communication between different teams. Some of the contributing factors that we see, familiarity with each other's processes, so that we have consolidation with physician groups into hospitals or into facilities. We have scenarios where familiarity between the practices and the facilities, and we're seeing more and more silos of systems or hospitals where each of them have their own processes, their own procedures, their own way of doing things. So it makes it very difficult when those two different entities need to communicate and interact because there's no familiarity with how each other is operating. To be a pretty hierarchical and disruptive culture throughout the healthcare world right now. There's a very interesting video that if you get to take a look at it, it's fascinating. You can see it on YouTube. The name of the video is "If Healthcare Worked Like the Airlines." Type that in real quick. It's a 7-minute video, and or if air travel worked like healthcare, I think is what it's called. But it'll lit up either way, and it gives a kind of understanding as to how patients see our healthcare system. It's a woman who's trying to a flight from Washington, D.C. to Oregon, and all of the problems that we see in the healthcare system come into play in this particular video. And it's hierarchical and disruptive culture and disruptive system that patients are operating in on a daily basis. It also tends to be very fast-paced and very high stress. You look at high stress, high volume environments. Healthcare is always right there in the top 5 easily, and oftentimes in the top behind soldiers, police, and air traffic controllers. So it's a stressful environment that we work in, and that makes it much more difficult for us to effectively do what we're doing, particularly when it comes to communicating and handing off patients. So lack of standardized communication processes and tools is another contributing factor. Multiple providers in complex medical conditions with poor coordination. Again, watch that video. It just kind of plays a lot of these out. A contributing factor, unreliable medication reconciliation processes, transitions of care, and another topic that we had focused on early in this set of programs is documentation issues or documentation deficiencies. And if you didn't even mention as a contributing factor here, the EHR. We're still at that point, even though we have virtually full adoption of EHR in the hospital setting and high 80% of adoption of EHR in the clinic setting. We're still seeing significant issues as far as proper utilization, as far as being able to utilize documentation for care, being able to utilize the tools that are available electronically to do, like properly communicate, proper transition patients, properly work our way through the handoff process. Let's talk about inadequate handoff and some of the issues that we see related to that. So some of the areas where we see this, pardon me, the areas where we see issues with handoffs, not surprisingly, at shift change. My stepson is currently in the trauma surgical ICU at University Hospital in Columbia, Missouri, after sustaining an injury playing hockey, and witnessed this. I was actually working on this program while at the hospital today, and so a lot of these issues, it was an interesting perspective to be about transitions of care and thinking about patient handoffs when watching these providers do what they were doing. And it's a confusing time at shift change. You see doctors coming and going and nurses coming and going. So the transit from attending provider to attending provider, or nurses. changing shift, passing a patient from one nurse to another, changing nurses. They're done with whatever their work week may be. The process between specialists. We've seen a number of issues related to malpractice claims where you've got so many specialists, now so many subspecialists that are involved in patient's care that you get to the point of wondering who actually is in charge, who actually is carrying the torch of being the one in charge of a patient's care. I can think 6 or 8 malpractice claims right now where the results that delivered for tests that were ordered, and one of the specialists thought that the other specialist had responsibility for it, and vice versa. End up in a situation where if both think the other has it, nobody does. We've seen transfers from facility to facility. Still see significant issues and potential for the least arena, which is the misunderstanding or failure to understand the processes of other facilities. And then at discharge, we're going to talk about at the very end of the program what we call the most important handoff, which is that patient handoff at discharge, or even the inpatient setting. You discharge that patient from their visit, his or her visit at the end of whatever patient had come to see you in the outpatient setting. All these areas are ripe for opportunities, ripe for mishandling, ripe for miscommunication. We lead to unfortunate scenarios and poor outcomes. So challenges that we see with handoff, the signal-to-noise ratio, just basically the environment, that high-speed, high-paced, loud, chaotic environment that is healthcare that we see on a daily basis. One of the big challenges that we see, differing communication styles or changing communication styles. And one I can think of right now is this transition to electronic health records. Communicating from physician to physician. I can't tell you how many times I have had doctors recently say, I'm at a history and physical that is 7.5 pages long, and I'm looking to pull single nuggets from this 7.5 pages, and it's finding a needle in a haystack. Whereas in a written record, the history and physical was something that was easy to navigate. You could get right to the meat that you needed. So interesting to think about communication styles being attributed to the health record, because it's just significant change in the way that we operated just a few short years ago. That lack of teamwork culture, I think the positive changes as far as the culture of teamwork. My experience with Team Steps programs, with the understanding in the outpatient setting of just how much more effective, how much more efficient the entire patient handling process, the entire patient handoff process is. We're operating from more of a teamwork-based culture, seeing positive strides in facets of healthcare with that. But we definitely can get better. In those entities where they don't have a teamwork culture inherent in their facility or entity, we see issues with communication, significant issues, handoffs. No defined standards as far as what a proper handoff scenario is or what a proper transition of a patient is. Ambiguous moments of transition. This is a scenario where you've a physician changing shift, and so at 7 o'clock the trauma surgeon is off shift, but oftentimes it's not clear cut at 7 that doctor is gone. Oftentimes they're sitting around dictating or documenting or still working, and those moments in time where we don't know exactly who is in charge, as opposed to that clear, concise moment of transition of care from one provider to another or from one team to another. The challenge that we see with handoffs is when there's no clear high-risk triggers. There really isn't anything that we see as this is where high-risk issues come in the handoff process. Basically, every patient is an opportunity for a handoff issue. So it's not like there are clinical areas that we can look at and say we see more handoff or more transition of care issues related to this clinical type of patient. So the opportunity is there in all patients. The Swiss cheese model of risk management or patient safety, where things line up and they happen to line up just right so that the hole in the Swiss cheese goes all the way through and you end up with a patient injury. So no clear trigger as to what prevents a patient who would be an opportunity for an injury at the handoff or during the handoff process. We routinely, with interruptions, distractions, and multitasking, presents us with challenges during the handoff process. The more noise, the buzz that's going on, the more patients that we're dealing with, the more there is that unfortunate opportunity for something to go awry, for something to go wrong. And then cognitive bias. We've seen a significant number of issues where we can directly relate a misdiagnosis or a delay in diagnosis to cognitive bias, just like we see with handoffs and transitions and the challenges associated with those. So, book to look at how doctors think. He talks in this book about types of cognitive bias and to make sure that we're not allowing ourselves to slip into cognitive bias, particularly when we're looking from a diagnosis standpoint at differential diagnosis. So repetitive bias is where you get that 32-year-old male who was out playing soccer and in great shape and runs 4 miles a day and comes in and is experiencing chest pain, and because of how this patient presents themselves, you think that this patient can't be suffering a heart attack. And so attributing things to a patient that would lead you to think that something's not going on is a repetitive bias. Then attribution bias, that's where you label a patient as an alcoholic, or label a patient as a smoker, or label a patient as non-compliant, seeing them into a certain category, and by not giving them the full consideration really in an evaluation standpoint. Affects is where you care so much about a patient that you don't want to subject them to something negative or subject them to something bad. Anchoring is where is a bias where the very first diagnosis that you come to, the very first thought that comes into your mind, you latch onto that and hold on to it. Similarly, is take a set of symptoms, basically placing a patient into, or crowding a patient, or crowding those symptoms into a particular diagnosis, as in this where flu is prevalent in your area and someone comes in with some presentation of flu, and it's automatically attributed to the flu. Closure is where the very first diagnosis that comes up to play is held on to, and basically you close out any other opportunity to look at other issues that could have changed that diagnosis or changed that thought process that already came up. So kind of closing out the opportunity to look at any other issues that present from that particular patient. So we're going to get some specialties now as related to high-risk areas, and look at the issues we see related to these specialties. And the first one that we see is hospitalists, what we call the black hole effect. Our business, as far as exposure to patient injury and malpractice claims with hospitalists, is a point in time when the patient is being transferred from the inpatient setting back to the primary care setting. The studies are quite staggering when you look at them. During that transition, less than 34% of primary care providers receive discharge summary prior to the first post-acute care visit. So often we have patients who show up for a first appointment after having been in the hospital, and the primary care provider doesn't even know that the patient had been in the hospital. So we need to get better at that communication and that handoff, because that's what this is. It's a handoff that takes 3 or 4 days to occur. But that lack of communication between the hospitalist and the primary care provider really exposes both of them to significant problems, and exposes the patient to significant patient injury with that lack of communication and that black hole that opens up at that point in time when a patient's moving from the inpatient setting to the outpatient setting. Lab, radiology, and procedure reports are left out of the discharge summary 65% of the time. So where the CAT scan has been ordered, but the report hasn't been received or hasn't made it back into the hands of the hospitalist, and so the patient is then discharged, and we don't even know what the results of those particular things were. Completed diagnostic reports are left out in 38% of the cases. So this is a scenario where the hospitalist has ordered a study, received the results of the study, and don't have the report of that study placed into the discharge summary for the primary care physician to look at. And new medication lists are not provided in 21% of the cases. So we recognized these breakdowns in handoff, these breakdowns in communication, and we've got to make sure that we're doing better, our patients, and doing better at this handoff process. So it's interesting to look at how dependent we become on electronic health records and how often we ignore or bypass an opportunity to communicate verbally because of the use of EHR. I think how often, when I was X-rays, how often the radiologist picked up the phone, called the doctor outright, and in what I see today, that just doesn't happen anymore. The reliance upon EHR and the fact that we have been sold so hard on ER replacing open lines of communication and the need to communicate verbally, that is something that we've got to get away from. And this is a prime example of it here with this hospitalist referring back to the primary care physician. I think if we see open lines of communication, if we see scenarios where the physicians are talking, a lot of the issues related to discharge summary and to primary care physicians not understanding or not having an idea of what that patient has experienced or what that patient was subject to disappear simply by picking up the phone and talking. So the higher risk area we're going to look at is obstetrics. OB saw in the first set of slides that we utilized. There's a frequency issue with OB. We don't see a lot of OB claims, but unfortunately, associated with those claims is extensive. No two on our list of when we look at indemnity paid. So what we see as issues in OB, failure to recognize and communicate abnormal heart rate tracing, no big surprise there to anyone who deals with this. The appropriate use and management of patients such as oxytocin, failure to adopt evidence-based standards, and improper performance of operative vaginal delivery, primarily shoulder dystocia. Here, if you look back at why CRICO rates are 60% of other OBs, they looked at communication, they looked at patient handoff, and looked at a number of clinical indicators that led to shoulder dystocia or the potential for shoulder dystocia, and virtually eliminated shoulder dystocia cases in their insured base. That's the most significant reason that they were able to reduce their rates so staggeringly. A lot of those are arguments that focused on the contributing factors as opposed to the clinical factors. Looking at the communication issues, looking at teamwork issues, looking at handoff issues and follow-up systems. You look at the CRICO data, 36% of OB claims in the CRICO data are due to miscommunication, and 26% of claims are due to documentation deficiencies. And look at that, we can make a difference in communication error. We can make a difference in documentation deficiencies. It's difficult for anyone from the risk management and patient safety standpoint to go out to an OB physician and say, birth baby's better. From a standpoint, it's difficult to impact. But a contributing issue from a contributing factor standpoint, there are things that we can address to reduce errors in communication, errors in documentation, and the like. High-risk areas is surgery-related handoff issues. Communication and handoffs among the healthcare team are the frequent root cause of surgical patient injuries, and wrong side, wrong procedure, or wrong person surgery claims are often the result of faulty communication, and patients are particularly vulnerable to adverse events during the post-operative period. So I don't think that these are areas that come as shocking or out of the ordinary. A lot of the handoff issues that we see can be directly tied back to faulty communication amongst the team, faulty communication between the team and their patients. So it's important to remember that most surgical patients spend very little time in the hospital during the recovery process, and I think that is becoming more and more prevalent. In the outpatient surgical setting, it's striking the depth and breadth of procedures that we do now. So the majority of the recovery that we see post-surgery happens when we're in some sort of post-acute care setting. And so that communication at the handoff with the patient or with the patient's family is becoming more and more important and more essential. So again, kind of drawing that line and connecting those dots between written and patient handoff issues and transitive care issues directly to communication. Risk areas and handoff and transition, emergency medicine risk factors, and what ED or in the ER is that you've got a very unpredictable patient load that can change with wind, where it can be dead calm, the next minute it can be overloaded. The severity of patient conditions from cold to some severe trauma we can imagine. Very noisy environment, very chaotic environment whenever we see issues related to patient handoffs. Most of the time it is that signal to noise ratio, that chaotic operating environment that's working in the ED. The multitasking requirements of physicians and staff, if for no other reason than seeing multiple patients and seeing multiple patients with multiple different injuries or multiple different presentations and multiple levels of severity. So providers and different teams coming and going need to refer out to specialists. The utilization of specialists and subspecialists routinely in the ED presents high risks, and the multiple transitions of care, shift change, and patient discharge. So we're dealing with doctors coming and going, we're dealing with nurses coming and going, and then we're dealing with patients that are coming and going. All of these transitions, all of these handoffs present the opportunity for something to be missed, for something to be dropped, for something to be forgotten. Which again, that's where we see the opportunity for the patient injury. So I added the outpatient setting here. There wasn't too much talk of the outpatient setting when it came to transitions of care or patient handoffs. And I think that that's doing a disservice to what we see routinely going on in the outpatient setting. I think that the use of hospitalists has placed a stressor on that point where physicians are dealing the handoff coming from another provider. And I think that we're still new in the hospitalist movement. We're at a point in time where we don't have a full grasp on how significant the issues or the lack of information or the lack of communication can be, and just how ripe those times are for injury. So The increase of specialists and subspecialists, we're not changing with that. We're seeing more and more use of subspecialty. And so any time that you add another player into the mix, we see further opportunity for miscommunication or dropping of the ball. I'd like to discuss it just briefly, but the communication stressors and pressures that are placed and have been added because of the use of EHR present high risk in the outpatient setting. Looking about patients moving through that system, looking about handoff, particularly from the doctor to the patient when the patient's leaving out of the outpatient setting. That traditional communication in the healthcare community, I think that this is something that should be focused on more intently. I think that is something that can be fixed. We've got to get back to relying on our ability to verbally communicate with other players in the community. I think a lot of the issues that we see, a lot of the errors that we see related to communication, handoff into patient transitions, would be done away with if there were more verbal communication. Consolidation in the healthcare system, physician moving into that employed model is a risk for us in the outpatient setting. Having to operate under processes and procedures that are unfamiliar, basis stressors, errors that we haven't seen, not at least to this level, more and more for this falling out of that employee model. And again, communication errors result from that. Pay transition errors result from that. We haven't discussed much about follow-up system errors tonight, but we see so much of the lab radiology and other procedure reports or the delivery of those reports, the cracks. And when you look at patient handoff, so often the patient handoff error isn't moving from provider to provider or from physician to physician or from facility. It's movement of that patient without the correct medical information, without that CT report, without the most recent blood pressure information, or without the most recent medication that the patient received. It's not as much that failure of transition from person to person as it is that of transition without the needed information or without the correct information that should be going with the patient. And on that list is struggles with patient engagement and orientation. We have been focused pretty intently at MMIC on development of an engagement program. And I started the research on this because my impression was that it's a scenario where we need to work toward patients to be involved in their own health care. And we find is it's more getting healthcare providers, getting nurses and doctors, techs and lab technicians to open up their arms and invite patients in. And for the part, patients tend to be fairly engaged. It's just that we don't take advantage of that engagement. And that was really shocking to me. More did my research on this particular topic, because my impression was that it was the patient who wasn't involved. And what we find is, and what all of the research indicates, is that we don't do a good enough job in the healthcare world of allowing patients to be involved. So it's going to be a change that we see. There's going to be more and more focus placed on patient engagement, patient orientation. And what we know is that when you've got an engaged patient, when you have a patient who is oriented to the practice and oriented to what's going on around them, the risk of error at the handoff process drops significantly, because it's not a patient just being blindly led throughout the system. It's an engaged patient and an oriented patient is part of the process. And a lot of these handoff errors that we see be alleviated and with simply by having a patient who's involved and a patient who can speak up, and a patient who can be participatory in the entire process, including the handoff side of the house. We run down some of the risk management and patient safety strategies that we see, and then we'll talk about the patient handoff, and we'll be through. Do everything that you can to limit distractions and environmental noise when handing off. We talked about that signal to noise ratio a couple of times tonight, and it's staying aside and focusing specifically on the handoff process when that's what you're doing, leaving that noise around you, focusing on that one moment reduces that potential for error. Allowed more time and establish a method for question and answer during the handoff process. It's a set of time where you're taking time away from the patient, but what we see is that when effectively done, when effectively communicating at that transition, when getting good and pure information, the risk for injury to the patient decreases significantly. Utilization of standardized communication throughout the process, such as SBAR, I'm talking about situation background assessment and recommendations, and standard handoff templates. To standardize this process can be with utilization of outliers, making sure that if there is something that falls into critical value, if there is something that's an alert, that there's an area for that to be noted separately, that there's an area for that to have the red exclamation point after it, so that we draw attention to those issues that fall outside of the standardized processes, but the utilization of the standard communication and standard forms in conjunction with those alert issues, a great way to keep issues from happening at the handoff time point. Specific information on handoff templates, either paper or electronic, such as the main complaint, the current condition, recent changes in condition, medications, treatment test results, pending test results, anticipatory guidance, and next steps. These things sound simplistic and are, but these are the basics that everyone should know. It's really easy if you think about a nurse or a physician having worked with a patient for 12 consecutive hours. There's so much that's taken for granted because you've been with that patient for 12 hours. When this being handed off to the next nurse, the things that have been taken for granted, you don't think about relaying, you don't think about passing on. So it's a lot of those basic things that fall through the cracks. By using the handoff templates, we can keep a lot of those basics to the forefront. It's almost the scenario that I mentioned with history and physical. You want the person who is picking up that patient during the handoff process to have to dig for information. We want particularly the important things right there in front of them. Simply being and implementing a handoff policy and proceed so that everyone understands the expectations of that handoff moment. If it's fine, if it's not clearly delineated, right for error. Providing handoff communication training and education for physicians and team members. Seeing that team impact, seeing that team approach. I think simply providing that type of training and everyone understanding what is expected at the handoff time point. Again, reduction in error is significant, just having clearly defined expectations. And then communication training for physicians and team members, focusing back on what we've already looked at. Another one of our big focuses at MMIC on patient and team communication. So this kind of digs a little bit deeper into the follow-up systems that we talked about. The implementation of an effective test management follow-up system. Again, defining what we expect from follow-up, we expect to get from results. We've seen some issues recently where our expectation was that we would see a decrease in follow-up system errors with full implementation of EHR, and unfortunately just the opposite has happened. Oftentimes because critical values in an EHR make a ding just like a normal lab coming through. So we've got to have a way in systems to draw attention to critical labs, to critical results, to outstanding type results. The IT that provides alerts, results, or return. viewing of results, red flags abnormal results, and allows documentation of notification. Again, this is what we expect and what we like to see out of proper follow-up systems, and there are ways to leverage IT and to leverage EHR to make sure that these things are happening. Implement test result follow-up policy, process the roles and responsibilities of all the individuals involved, implementation of critical test result policy so that results requiring immediate attention and action are communicated as soon as possible. Again, simple, but so often we see where there's that critical lab or that critical test or that outstanding test, and that information is not communicated or not effectively communicated during the handoff process, and this kind of disappears off into nothing. Verifying reliable patient contact information before discharge in case there is some issue where the patient needs to be called afterwards. Make sure that the medical record documents that patient and primary care physician or specialist have been contacted regarding test or imaging results. Think about that black hole effect and just how prominent the lab getting that information is when going back to the primary care physician. And then evaluate and monitor the ordering and test management system by routinely performing medical records and system audits. We would find these types of issues during an audit, then these issues by a patient being injured. The last two slides for tonight talking about the patient handoff. This is likely the most risky and the most important handoff of all, where a patient is being discharged from the practice or being discharged from the ER, being discharged from the hospital. And so it's across all specialties and all care areas. And what we see is that health literacy issues significantly compound this patient handoff. So some of the strategies that we have for this area, make verbal discharge instructions patient-centered and delivers that patients can understand the utilization of plain language. The fact is the average American reads on a 5th grade reading level, and if you look at discharge instructions, they're usually written at about a 15th grade reading level. Things to be objective and have specific criteria, particularly with what to do with their condition and talking about the next steps that they should expect and what to do if the expectations don't occur. Scheduling of any necessary follow-up appointments before a patient is discharged, communicating the need for follow-up care and the risks of failing to follow up. No news is no news. And so often we have said that no news is good news, and we need to get away from that. Make sure that we're using patients as a last line of defense in helping themselves from a care standpoint. Identify when and how pending lab results will be communicated to the patient. Encouraging patients to carry a personal medication list. Again, always getting back to that patient orientation and patient engagement. Help patients update their personal medication list if medication changes are made, and use utilization teach-back method to verify that patients understand the discharge instructions that they've been giving. Studies that we have working at patient engagement at all times during the care process. The more engaged patient we see, the more involved in their own health care they are, the less opportunity for something to go wrong at transitions of care and at patient handoffs. Orientation of your patients is rather simple, but telling patients what they should expect from the process before they go through it allows them to be engaged in the process. Use of communication tools like the AIDIT program, a program that we see out there that has staff following a set curriculum when addressing and talking with the patients. The AIDIT stands, let me see if you even remember, the AIDIT stands for acknowledge the patient and identify, as far as identifying who you are as a healthcare provider, the duration, so telling a patient how long they should expect whatever it is to take, an explanation of what they are about to experience, and then B is for thank you. Be alert for the health literacy and general literacy issues. If you recognize that there are issues with a patient from a health literacy standpoint, making sure that we're taking the extra time that they need to get the information across. And the thing that we talked about during the patient communication program that we did, allowing your patients to talk. So often we have that interjection that we have an interruption. Patient isn't allowed or doesn't have the time or isn't given the time to properly communicate their views and their concerns. Shut a patient out like that, the opportunity for something to go wrong at handoff just increased drastically. So I went a little over tonight. This is the first time I've done this program, but I'd be happy to answer any questions if you have them out there.
Okay, Robert. Any questions for Robert this evening? Okay, well, hearing none at this point in time, Robert, I know that you're always very good about making yourself available. You have your screen up there with your contact information. If anybody who walks away from tonight's presentation has questions for you, are they free to contact you?
Please, is there, and I don't have my phone number here, but feel free to drop me an email, and I'd be happy to give you a call back or answer anything that you have by email.
Robert and your team at MMIC for working with us on these programs. In closing, we want to again thank Robert for all of his help and want to make mention to you that this was the 5th in our 6th series of programs on risk mitigation, and so we have one final presentation coming up, and that is scheduled for February 2015, and that topic was on working with and supervising allied health professionals. And then I want to mention to you that this program tonight will be recorded, and all programs that we've done previously have been recorded and are all available on the SDSMA's website. With that, Robert, any closing thoughts?
Appreciate the opportunity, and if you have any questions, please feel free to contact me.
Great, and I do know again that you make yourself available, and you've even come out and done some on-site consultation, and so we appreciate that.
No, that's what we're here for. Thanks, Mark.
Okay, much, and wish everyone a good evening.